Let's talk about ECG basics. Now, this is an ultra fast refresher talking about general rule of thumbs about how to interpret the foundational things about ECG interpretation and leading up to the advanced section that you're going to be going next. Now, there's an understanding that you have some experience with interpreting ECGs, but let's actually go about it. Now, when you get a printout from an ECG machine, how do you interpret it? The way I was taught was you should fold over the part that the computer interpreted and then use your eyeballs to do it. Now, is that realistic? I'll be honest, it's not that realistic. The computer, although it's not perfect, can actually help you, but you just have to know some caveats. Again, it's not perfect, but you want to verify the calculations with your own eyeball and make sure that it actually makes sense. You do not want to rely on the computer's diagnostic impression, but you do not want to ignore them either. If the computer readout is saying acute ST elevation MI suspected, okay, you got to pay attention to that. But if a patient in front of you is like 20 years old, completely asymptomatic and doing fine, well, it's not making a lot of sense. You want to double check everything that's there, but you do not want to ignore something if the red flag is identified by the computer diagnostic impression. If you have access to old ECGs for your patients, and sometimes you don't, oftentimes you don't, but if you do, definitely want to use them because that abnormality you see on the ECG may have existed for a long time for that patient and nothing has actually changed. Now, the way that I systematically approach ECGs is this mantra: rate, rhythm, access, intervals, enlargement, and ischemia. I've done this over and over again to the point where it just becomes second nature to me, but this is a good place to start to systematically approach how to interpret ECGs. Now, a quick refresher. So remember that there's a reference pulse that's present on every ECG that tells you what the general reference standard is going to be. And this is your typical 1 centimeter reference pulse. And relative to that, you can see that the small box is going to be 1 millimeter by 1 millimeter, which represents 40 milliseconds of time, 0.1 millivolts in amplitude. You'll hear me say a lot in millimeters in amplitude. And so I'm not going to be using millivolts, I'll be using millimeters. And then the bigger box is comprised 5 by 5 of the smaller boxes. And that's going to be about 200 milliseconds in time and about 0.5 millivolts in amplitude, or it's 5 millimeters, right? All right, so that's your reference point. Now, when you calculate rate and rhythm, you're going to be looking at the rhythm strip. And the way that I calculate rate is I actually like the calculations 300 divided by the number of big boxes or larger boxes between the R to R waves. Some people like to just remember 300, 150, 175, and use that as they count each of the boxes between the RR waves. I just like calculations. It's about the same thing. When you look at the rhythm, you want to make sure that there's a P wave before every QRS and that there's a QRS complex after every P. And so again, you want to look at the rhythm strip. Typically in the ECG printout, it's the last two lines on the ECG. This one only has one, it's lead 2, but sometimes you'll see V1 as well. And this is the lead 2 and V1 are the ones where you can see the P waves the best, and that's why they're the rhythm strips. You can see here, look at the R to R interval, right? Or the R to R wave. You can see general count with me, 1, 2, 3, 4, 5, 6, 7, 8 boxes, right? So there's 8 large boxes between the RR. 300 divided by 8, it's about 40-ish. And you can see that the rate up here, yeah, it's about 40. Okay, that makes sense. And then again, look at the P. There's a QRS after every P, and there's a P wave before every QRS. And so there's other more specific criteria to determine normal sinus rhythm, but this is normal sinus rhythm. So looking at axis, it's specifically about the QRS axis. Again, you can look at the calculation the computer provides, or you can use the 2 thumbs rule, which is what I'll do to actually eyeball and verify that the calculation is generally correct. To know what the normal QRS axis is going to be, normal is between -30 to 90. And some textbooks vary on that criteria, but in general, -30 to 90 is normal QRS axis. Once you hit -30 to -90, that's a left axis deviation, as opposed to 90 to 180, right axis deviation, and then in this no man's land is extreme axis deviation. So again, here you can actually see on the computer printout, the QRS axis is 14. So it's between -30 and 90, that is normal axis. Now, the way that I like to verify that is actually taking your thumb. So do it with me right now. Take your left thumb, okay, and that's gonna be your lead 1, okay? And then take your right thumb, and that's gonna be lead AVF. Now, you want to use your thumb up or thumb down to reflect the general positive deflection of the QRS complex. So looking at this ECG, the general QRS complex is positive, so it's up in 1. And in general, if you look AVF, it's up in AVF as well. So 2 thumbs up. That means that I'm in a normal axis. Now, if it's up in 1, and if it's generally down or negative in F, so that's a thumbs down in F, look at your thumbs. With your thumb down, you're going to the left. You see that? And then if it's up in F but down or negative in 1, again, look at your thumbs, you're going to the right. So that's a right axis deviation. If you have 2 thumbs down or both negative deflections and 1 in F, that's bad, extreme axis, hard to interpret. And that makes sense in general if you look at the actual quadrant. So if you're positive vector, if you're up in 1 and you're up in F, you're in this quadrant, which is a normal axis quadrant. Again, if you're up in 1 but down or negative in F, now you're in the left axis deviation quadrant. And then if you're down in 1, so negative in 1, but up in F, that's a right axis deviation. And both negative is going to be in this, again, extreme axis. So that's the 2 thumbs rule. Now, when you talk about intervals, normal intervals for PR is between 120 to 200 milliseconds. Normal QRS is 80 to 100. A normal corrected QT is going to be less than 440 milliseconds. And I specifically mentioned the corrected QT because that accounts for the heart rate as opposed to the QT, which can be a little bit inaccurate. So let's take a look at this ECG tracing. So the PR interval starts at the beginning of the P wave until the beginning of the QRS complex. Now the QRS complex itself is from the Q to the S, makes sense. The QT interval is at the beginning of the QRS complex to the end of the T wave when it comes back to baseline. Now, again, when you look at the calculations that the ECG machine does for you, it's all nicely printed out for you all in one place to just quickly verify if it meets the actual intervals. You can eyeball them as well. Let's go through all the different abnormalities. When you have a fixed prolonged PR interval, and as you can see here in this example up to the left, this PR interval is greater than 1 large box, and it's fixed with every QRS complex, and so that's a first degree AV block. When you talk about a prolonging PR interval that's enlarging with subsequent beats, here you can see it's bigger until it drops. That's a second degree AV block type 1. And then when you have intermittent dropping of QRS complexes, you see this P wave, but there's no QRS. P wave followed by QRS. P wave, P wave, P wave, but the QRS is not present after every P wave. That is a second degree AV block type 2. Now, when you have complete dissociation between the atria and the ventricles, you can see that the ventricles have an escape beat, a junctional beat with a widened QRS complex, and it's at a low rate, about 40, whereas the atria is still firing at regular intervals. You can see this P wave right here. This one's buried in that QRS complex, but you can see it and track it through. Now, when you have shortened PR intervals, especially when you have an upsloping of the QRS complex right here, shortened PR interval less than 80 with this upsloping, now that's a delta sign that's concerning for Wolff-Parkinson-White syndrome. All right, when you talk about QR interval abnormalities greater than 120 milliseconds, the most common thing that you're going to be thinking about and you want to identify are bundle branch blocks. Now, I always got confused between right bundle and left bundle, RSR prime and RS, all that stuff. For me, this is the way I remember it. If you look at me right here, the V1 lead goes right here, V2, V3, V4, V5, V6, right? So the right side is V1. The left side, where the left ventricle is, V6. All right. And so now looking back at the CCG, you can see that when you have a bundle branch block in the right, so you're going to have conduction delay in the right ventricle, the QRS, the R complex is actually widened in V1. The positive deflection where the right ventricle is pointing, that's going to be widened, as opposed to on the opposite side, V6, now you're looking from behind. So it's going to be a negative deflection. The S wave is going to be widened, as opposed to in left bundle branches. Remember, V6 is looking in the direction of the left ventricle, so the positive deflection is the left ventricle. You see the R wave is widened, as opposed to if you're looking from behind, the negative deflection in V1, the S wave is widened. You see that? So that's how we're identify and distinguish between right bundle and left bundle branch blocks. Now, when you talk about QT interval abnormalities, it's primarily going to be prolonged QTs. And again, look at the QTC. But the way I eyeball it is look between the R waves, and generally the T wave should come back to baseline before the halfway point between the two. And so you can see here that here's R wave, and the T wave should have come back to baseline by this point, but it's still repolarizing. And so that is suggestive that there is QT prolongation. Now, when you talk about enlargement, there are a lot of criteria. I often have to look it up myself just to verify it. But the easiest way is look at V1, lead V1. You look at the P wave, the R wave, and the S wave. When you talk about atrial enlargement, right atria and left atria, remember with V1, that's the right side of precordial leads, right? So the atrium on the right If you have enlargement of that, the P wave, the height or amplitude, will be greater than 1.5 millimeters. As opposed to left atrial enlargement, you're looking from behind now. So V1, you'll have a biphasic P wave with the terminal negative portion that's greater than one small box. So you can see here on the left, the P wave amplitude in V1 is larger than 1.5, suggestive of a right atrial enlargement, as opposed to V1, again, in this area, it's biphasic, and this negative terminal portion, which reflects the left atrium, it is greater than 40 milliseconds in time and greater than 1 millimeter in depth. So that is greater than one small box, suggestive of a left atrial enlargement. When you talk about ventricular hypertrophy, generally you're going to be looking for, and it's easier to identify left ventricular hypertrophy. But there are a lot of different criteria you have to fulfill in order to say that this is LVH or RVH. This is super simplified general rules of thumb. Sokolow-Lyons criteria is the most commonly used one, and that is where you take the amplitude of the S wave in V1 and you add it to the amplitude of the R wave in V5 or V6. If that's greater than 35 millimeters with left axis deviation, you probably have left ventricular hypertrophy. Tight QRS has to be there too. When you look for RVH, you're looking at V1, the R wave amplitude. So you're looking for at least 7 millimeters R wave amplitude with right axis deviation, and that generally will suggest RVH. But you want to be careful about posterior MIs. We'll talk about that in a little bit. Now, finally, when you come to ischemia, you're looking at the Q waves, T waves, ST segments, and they all are relative to contiguous leads, which we'll talk about at the very end. So let's start with Q waves. Now, first of all, there's a distinction between pathologic Q waves and non-pathologic Q waves. But I have to say, first of all, that just because you do not have a pathologic Q wave identified in ECG, that does not mean that, hey, there's no ischemia or infarct. As we all know, the presence of pathologic Q wave is concerning, but the absence of it does not say that you do not have to worry about ischemia or infarct at all. Now, the definition of the pathologic Q wave, you can see up here, there's a reference of 2012. There are multiple international societies. They came up with this universal ECG criteria of what defines a pathologic Q wave. It's a lot to remember. I put it out here and we're going to talk about it in a little bit, but more for your reference so you can take a look at it again when it comes across. But V2 and V3, any Q wave greater than or equal to 20 milliseconds or any QS complex is a pathologic Q wave. And then you see how 1, 2, AVL, AVF, and V4 through 6, any Q wave that's basically bigger than one small box in any two contiguous leads is considered pathologic. V1 and V2, if the R wave is at least 40 milliseconds with an R to S wave ratio at least 1 with a concurrent positive T wave in the absence of conduction defect, whew, that's a mouthful. That's basically saying, are you concerned about a posterior MI? And we'll see some examples of that. But in general, if you have an isolated Q wave in lead 3, that can be normal. All right. So here's an example of a QS complex or a Q wave that's greater than 20 milliseconds in V2 or V3, right? So you can see this right here. That is a pathologic Q wave. Now, when you talk about T waves, in adults, a T wave is normally inverted in AVR. And also, the definition of an inverted T wave is when it's negative greater than 1 millimeter. Okay, that's important because otherwise it's just a non-specific T wave. And the T wave has always have to be interpreted along with the ST segment. There are several T waves though, and there are several T wave morphologies you really have to be aware of because they can be concerning for ischemia and pending infarct. Hyperacute T waves. Deep symmetric inversion at least 3 millimeters of the T wave. Biphasic T waves and dynamic T wave changes are all red flags that you should be concerned about ongoing ischemia. And so when you talk about hyperacute T waves, it's this thing called the loss of precordial T wave balance. And so generally as you go from the right precordial leads in V1 all the way to the left precordial leads in V6, you want to see the increasing T wave amplitude. Once you actually see T wave amplitudes in the right precordial leads greater than V6, then the T wave amplitude of V6, that is concerning for possible hyperacute T waves. Also, especially in the right precordial leads, lead 2 and lead 3, V2 and V3, you want to be concerned if there's deep symmetric T wave inversions greater than 3 millimeters. That's suggestive of a Wellens syndrome. That's going to be left anterior descending coronary artery problems. And so, similarly, another Wellens morphology is biphasic T waves in V2 and V3, especially when you have a positive to negative deflection of the T wave. That is concerning for ongoing ischemia. Dynamic T wave changes, if you had something that was positive in the past and now it's negative today, that would be concerning as well. Those are all things you want to be concerned about. That's why old ECGs can be very helpful. All right, now let's talk about the ST segment. Now, there are a few things that we have to lay ground rules as far as like where do you measure the ST segment and where's the baseline for the reference point. ST segment technically starts at the J point, which is the junction between the QRS complex and the actual ST segment. And so you can see in this example, the QRS complex ends and changes right here. You can see that right there. And then again, right here, that is the J point. That's where you're going to be measuring the ST segment, either elevation or depression. But where's that reference point? Where's that baseline upon which you're comparing that depression or elevation? That baseline is the PQ junction. At the end of the PR segment, you can see right here as the QRS complex takes off, this is going to be your baseline from which you're going to be measuring. You can see about a 1 millimeter ST depression in this example. Now again, that universal electrocardiographic definition of what is ST elevation and my criteria, it's new ST elevation at the J point in at least 2 contiguous leads. We'll go over the contiguous leads at the end. However, for all leads other than V2 or V3, it has to be at least 1 millimeter in 2 contiguous leads, but specifically for V2 and V3, it becomes a little bit more complicated. In men at least the age of 40, it's going to be at least 2 millimeter elevation. If you're younger than 40, for men, it's going to be at least 2.5 millimeter elevation. In women, again, this is all V2 and V3. If you have ST elevation at least 1.5 millimeters in women, that would also be consistent with ST elevation and my criteria in the right clinical setting. Now, for those that are not ST elevation MIs, but you are concerned about possible ongoing acute coronary syndrome, unstable angina, ongoing ischemia, at least in 2 contiguous leads, if you have new horizontal downsloping ST depression at least 0.5 millimeter, and or T-wave inversion at least 1 millimeter with prominent R wave or R to S wave ratios greater than 1, that would be concerning for ongoing ischemia. Now, when you talk about downsloping horizontal, what does that mean? It's about the morphology of the ST segment. You see how this is upsloping ST segment versus this is downsloping ST segment, whereas this is a horizontal ST segment. So, in general, the classic ECG evolution of a myocardial infarction within the first few minutes, that's where you see the hyperacute T waves and ST elevation. And minutes to hours is where you see the ST elevation and the T wave inversions. And then days is going to be where you see the pathologic Q waves with infarction. Finally, to wrap all of these things up, the coronary artery localization. What are those contiguous leads? We're trying to localize the ECG to the coronary artery anatomy. And in general, you can see with the vectors here, 1 and AVL are the lateral leads versus like the V5 and V6 is also lateral leads versus 2, 3 and AVF, which is the inferior leads. And then V3 and 4, some will include V2, is the anterior leads. V1 and 2 can be septal. How does that correlate to the coronary artery anatomy? Well, the 2, 3 and AVF, which are the inferior leads, correlates with the right coronary artery versus 1 and AVL with V5 and V6, that's the lateral leads, left circumflex, versus the anterior leads, which is V2, 3, 4, left anterior descending. So you can see, again, on this ECG, 1 and L, lateral, V5 and 6, also lateral, inferior 2, 3, AV and F, and then V1 and 2, people call septal, 2, 3, 4 will be anterior. And there's this mnemonic. It's not a perfect mnemonic by any stretch of the imagination, but sometimes you can look for reciprocal leads to the ST elevation. Reciprocal changes are basically ST depression. So if you have a posterior infarct, you may see anterior depressions, ST depressions. If you have anterior ST elevations, you may see inferior reciprocal changes, ST depressions, the inferior leads, and so on and so forth. So if you have ST elevation inferior leads, you may see ST depressions in the reciprocal lateral leads. Lateral to septal. So let's take an example here. Let's look at this ECG. Where do you see the ST elevations? So the ST elevations you see in V1, V2, V3, V4, V5, and you also even see it in V1 and AVL. So those are ST elevations. This is the anterolateral ST elevation MI. And you actually see reciprocal ST depressions in the inferior leads, 2, 3, and AVF. So that is an anterolateral ST elevation with reciprocal ST depressions in 2, 3, and AVF. And in the right clinical setting, a person with crushing chest pain, that is something you want to call 911, get them to a cath lab now. Now, in this example, take a look and you can see some ST elevation in 2, 3, and AVF. Okay, and then you see maybe borderline ST depression in 1 and L. So this is an inferior ST elevation with possible reciprocal changes starting to show up in the lateral leads, especially in AVL. And so in that Pales mnemonic, it kind of makes sense. Inferior ST elevations with reciprocal changes in the lateral leads. So this is inferior ST elevation with some possible lateral ST reciprocal changes in depression. So remember, the next time that you review and interpret an ECG, just remember rate, rhythm, axis, intervals, enlargement, and ischemia.